Okay, it's ECT, electroconvulsive therapy. So this patient's severe depression, loss of interest, excessive guilt, sleep and appetite disturbance, and auditory hallucination are consistent with major depression with psychosis. Major depression with psychosis marked his marked weight loss and refusal to eat and drink require urgent treatment. According to multiple evidence-based guideline, first-line treatment for psychotic depression consists of either an antidepressant plus antipsychotic or ECT. Because ECT is generally faster than pharmacotherapy, it is used to achieve a rapid response in depressed elderly patients who are unable to eat or drink, psychotic, or actively suicidal. ECT involves uh, ECT involves inducing a 30 to 60-second generalized tonic-clonic seizure. Hemodynamic changes are brief and cardiac complications are rare. Amnesia is one of the most common side effect. Amnesia is one of the most common side effect. Antidepressant typically take up 6 to 8 weeks for response and must be combined with antipsychotic medication to effectively treat major depression with psychotic feature. Although the patient's condition previously respond to TCA, antidepressant monotherapy would be inadequate, and ECT is preferred due to the need for rapid response in severely depressed patients who is not eating or drinking. Okay, so it's PTSD. So this patient has a history of exposure to intimate partner violence and has several features of suggestive of PTSD, including sleep disturbance, poor sleep, panicked awakening, dissociation, momentarily staring and unresponsive negative mood, and hypervigilance, increased startle response when nearby door slams. Characteristics features of PTSD include flashback, intrusive memory, and avoidance of reminders of the traumatic event. Patients with PTSD commonly experience depressed mood, irritability, and anxiety, and frequently have classic mood symptoms such as insomnia, fatigue, impaired concentration. Patients may be reluctant to disclose trauma, so physicians may remain alert to signs and symptoms of PTSD and provide further assessment and treatment. Trauma-focused cognitive behavioral therapy and antidepressant are the first-line treatment. So these patients onset of anxiety and insomnia in response to a major life change. Living alone for the first time is most consistent with an adjustment disorder. Our insomnia and increased anxiety develop in relation to safety concern about being alone and fears of intruder at night. Her fatigue in turn negatively impacts her studies. An adjustment disorder involves emotional or behavioral symptoms, anxiety, depression, disturbance of conduct, developing within 3 months of an identifiable stressor and lasting no longer than 6 months once the stressor ceases. Symptoms of adjustment disorder are distressing and impairing but do not meet the criteria for another psychiatric disorder. Symptoms are insufficient in number, severity, or duration for another specific diagnosis. Stressor can be single or multiple. In these cases, they are multiple: moving away from home, living alone for the first time, and starting college, feeling academic stress. Okay. Is it serotonin syndrome? Oof. I was confused in between. Okay, Stacy. So this patient's presentation suggests MDMA intoxication complicated by the serotonin syndrome. MDMA, formulated as ecstasy or Molly, and has mild hallucinogenic properties, is sometimes used by college students during parties to cause euphoria and increase sociability, alertness, empathy, and sexual desire. MDMA is a synthetic amphetamine that exerts its effect by increasing synaptic clefts of norepinephrine, dopamine, and serotonin. Severe intoxication may manifest with features of sympathomimetic toxicity, hypertension, tachycardia, diaphoresis, hyperthermia. Serotonin toxicity, serotonin syndrome, altered mental status, hyperreflexia, myoclonus, seizure, and hyponatremia. Combining MDMA with other serotonergic drugs, sertraline, as in this patient, further increases the risk of serotonin syndrome, coma, and death may result from acute intoxication, and long-term use have been linked to neurotoxicity. Recreational synthetic amphetamine and analogs MDMA and bath salts may not show up amphetamine in routine urine toxicology screen. Okay. For how long? Is there any? Okay. This patient exhibits acute psychosis, grossly disorganized speech and behavior, probable hallucinations that are most likely due to schizophrenia. Definitive diagnosis of the schizophrenia requires of ruling out other psychotic disorders, mood disorder, with psychotic feature, substance-induced psychosis, and psychosis secondary to general medical condition. Because the patient is cooperative, initial treatment of oral antipsychotic medication is appropriate. Medication selection depends on the patient's history of response as well as medication side effect profile. Second generation antipsychotics such as aripiprazole are often chosen due to their low risk extrapyramidal side effect and tardive dyskinesia compared with first generation antipsychotic, with the exception of clozapine. There is no evidence that one psychotic is more effective than other. If further evaluation indicates a pattern of repeated medication non-adherence, switching to a long-acting injectable antipsychotic could be considered. However, this should be done only after the patient's ability to tolerate oral formulation and therapeutic doses is established, making long-acting injectable antipsychotic inappropriate choices as initial agent. If the patient tolerates and responds well to oral aripiprazole, then subsequently switching to long-acting formulation of aripiprazole could be considered. Next, yes. Yes, maybe OCD. She never want to. So SSRI. Okay. Uh, do you want me to read the explanation or we can proceed? Yes. Okay. Obsessive compulsive disorder. Obsessive compulsive disorder is diagnosed by the presence of obsession, compulsion, or both, with most patients having a combination. Obsession are characterized by involuntary, intrusive, distressing thoughts, involuntary, intrusive, distressing thought images or urges are managed through suppression or neutralization with a compulsion. Compulsions are repetitive, unyielding, external or hand washing or mental repeated counting acts designed to protect against the obsession or reduce distress or anxiety. In some cases, obsession in OCD include unwelcome, violent urges or images as seen in this patient who has images of stabbing her mother of in the back with a knife, followed by a compulsion of repeatedly counting 5 to 1 neutralize the thought. Line treatment of OCD includes first line first mm, first line treatment of OCD includes response prevention exposure or response prevention by a cognitive behavior therapy and pharmacotherapy with a serotonergic antidepressant All the SSRI, antidepressant, fluoxetine, sertraline, paroxetine, fluvoxamine, citalopram, and the tricyclic antidepressant clomipramine are effective. SSRI are preferred as initial treatment due to their superior adverse effect profile. Got it? Next. Just read the last part on neurological examination. Around in all of the in all of the disease, among all of the disease, one of them has Parkinson-like feature. Okay. My English sometimes sucks. Sorry for that. Okay. This patient's presentation is most consistent with dementia with Lewy bodies. Diagnosis of probable dementia Lewy body requires the presence of dementia, low MoCA, and two of four additional core features: Parkinsonism, limb rigidity, fluctuating cognition, good days and bad days, periodic confusion, visual hallucination occur in two of three patients but not required for diagnosis, and rapid eye movement sleep behavior disorder. In RBD, a parasomnia characterized by enactment behavior, loss of dream enactment behavior during loss of normal REM sleep atonia is a common and early symptom of DLB, dementia of Lewy body. Patients often have an early deficit in executive function, needing help with finances, shopping, and visuospatial ability, getting lost in the neighborhood. Depression, as seen in this patient, is common and occurs in most patients at some point of illness. Other symptoms include dopamine antagonist, antipsychotics, sensitivity, repeated falls, syncope, autonomic dysfunction, and delusion. Okay. Okay, nausea and vomiting during pregnancy affects many women in first trimester. Many women in first trimester is relatively mild and with no associated weight loss, hypovolemia, electrolyte abnormalities. Most cases of nausea and vomiting during pregnancy typically resolve typically resolved by the mid typically resolved by the mid second trimester. Therefore, management is usually supportive with dietary modifications, small scheduled meals, taking medications with food at night, and vitamin B6 pyridoxine therapy. However, some cases of nausea and vomiting during pregnancy can mask an underlying eating disorder, as in this patient with potential concerning findings. Weight loss is an already relatively low BMI. Weight loss with an already relatively low BMI, unpredictable appetite with skipping meals, followed by episodes of overeating, and distorted view of body weight and shape. Therefore, these patients require additional evaluation for disordered eating behavior, self-induced vomiting, purging, excessive exercise. In some women with eating disorder, pregnancy is added stressor that increases disordered eating behavior. Therefore, patients are at increased risk of obstetric complications, spontaneous abortion, low birth weight, microcephaly. Therefore, patients with an eating disorder during pregnancy will benefit from nutritional counseling, setting expectation for pregnancy-related changes in body weight and size, and psychotherapy to establish and reinforce eating patterns. Okay, risperidone causes hyperprolactinemia, and risperidone causes. Oh, no, 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 no. Go with your flow. Okay, I always get confused with carbidopa levodopa. Okay, sorry. Okay, dementia with Lewy body presence with dementia with Lewy body presence with dementia plus two of the following features: visual hallucination, Parkinsonism, fluctuant cognition, and REM sleep behavior disorder. Treatment with DLB include carbidopa, levodopa for Parkinsonism, and cholinesterase inhibitor like reverse treatment for cognitive impairment, and melatonin for REM sleep behavior disorder. A trial of medication risperidone may be indicated in patients with functionally impairing visual hallucination or delusion, but it may be prescribed with caution due to extreme antipsychotic hypersensitivity of patients with dementia with Lewy bodies. Antipsychotics may be associated with worsening confusion, Parkinsonism, and autonomic dysfunction when used in such patients. These patients' sudden increase in falls, confusion, orthostatic hypotension, and rigidity in most likely due to recent prescription of risperidone, an antipsychotic known for stronger dopamine receptor antagonism relative relative to other second generation antipsychotics. When antipsychotics are indicated in the treatment of dementia of Lewy body, evidence favors low potency second generation antipsychotic quetiapine. First generation antipsychotic haloperidol should be avoided entirely. Although carbidopa levodopa may produce orthostatic hypotension and confusion, it would not explain this patient's increased rigidity. Okay, carbidopa levodopa and other anti-Parkinson drug may worsen psychotic symptoms in dementia and Lewy body, but these risks can be minimized by cautions, dose titration as needed, the use of low potency antipsychotic. Yes, yes, he is on fluoxetine. It's serotonin syndrome, and there is hyperreflexia. Yes, sedation, the old theory of like in here there is specific antidote like cyproheptadine, but it is not given in. Yes, but benzo can be given. And in as far I remember, in neuroleptic malignant syndrome, there is a weird drug like bromocriptine, like A, option A. Look at the option A. Yes. So it is a weird answer, like bromocriptine for NMS. Cyproheptadine is not regularly used, so that's why we do not remember. Okay, I'm reading the explanation now. Okay, these patients are taking SSRI, this patient taking SSRI has altered mental status, autonomic instability, and neuromuscular excitability, a triad concerning for serotonin syndrome. Although it is typically follows an increased SSRI fluoxetine doses, serotonin syndrome can also be precipitated by concomitant use of another serotonergic agent. This patient recently began taking antitussive dexamethasone, which primarily activates sigma opioid receptor to inhibit cough, but also has a serotonergic activity at 5-hydroxytryptophan 2 receptor. Management often includes discontinuation of all serotonergic medication, management of severe hypertension, and short-acting antihypertensive, IV hydration and evaporate, and connective and convective cooling, fanning, water mist, and antibiotics are not used. Antibiotics are not used because hyperthermia is due to sustained muscle contraction, not elevations in the hypothalamic temperature set point. And benzodiazepine lorazepam to improve agitation, decrease muscle contraction, which reduces hyperthermia and decrease blood pressure and heart rate. Decrease blood pressure and heart rate. Next. Okay, so sorry. In patients who are unresponsive to benzodiazepine, cyproheptadine is used to lower the serotonergic activity through antagonism of 5-HT1 and 5-HT2A receptor. Serotonin syndrome can have a relatively rapid onset and progression. Some patients require intubation and sedation for severe hyperthermia. Yes. Maybe generalized. Okay. So these patients excessive concern about multiple issues. Her work not being good enough, kids laughing at her, intruders in the house, resulting in irritability, difficulty falling asleep, and poor concentration is suggestive of GAD. GAD in children can manifest as a need for perfectionism and order. When these are not attainable, coping difficulties is also seen. Other manifestations include somatic symptoms, stomachache, school refusal. Although the diagnosis of the GAD in adults require uncontrollable worry accompanied by three or more than three additional symptoms, restless, fatigue, irritability, only one symptom is required in children and adolescents. In children and adolescents. Okay, next. He has restricted behavior, isn't it? It's not Alzheimer, it's not Creutzfeldt-Jakob vascular dementia, mild. In between dementia and Lewy body and frontotemporal, there is one where there is restricted behavior. Yes, he has compulsions. Maybe. Lewy body, like in Lewy body, we will think about two things like hallucinations, like visual hallucination and Parkinsonism. And there is one like rapid eye movement behavior disorder. These three goes with the Lewy body. And frontotemporal dementia, like dementia, personality problem, and compulsion type of thing. Okay, so these patients' behavioral changes, socially offensive behavior, social withdrawal, compulsive behavior, hyperorality, apathy, lack of insight, and executive dysfunction, difficulty with tasks that require planning and are consistent with the diagnosis of behavior variant frontotemporal dementia. Disinhibition is often prominent component of behavioral changes in frontotemporal dementia. Unlike in Alzheimer's disease, memory impairment is generally mild with early frontotemporal dementia but worsens as the disease progresses. FTD typically presents around age 60, affects men and women at equal rates, follow an autosomal dominant pattern of inheritance up to 25% of the cases. The degenerative process of the FTD progress more rapidly than other dementing syndrome, Alzheimer's disease, and the average length of survival following diagnosis is 5 to 10 years. Behavior variant FTD is most often associated with accumulation of the tau protein inclusion known as PIX bodies in the hippocampi, temporal lobes, and frontal lobes. SSRI trazodone have demonstrated some benefits in the management of neuropsychiatric symptoms of FTD. Okay, next. Okay, it's Korsakoff syndrome. These patients retrograde or anterograde amnesia with intact long-term memory, confabulation, apathy, lack of insight, and history of alcohol use disorder are most consistent with Korsakoff syndrome. KS is a complication of Wernicke encephalopathy, an acute disorder of the thiamine deficiency characterized by the classic triad of encephalopathy, ataxia, oculomotor dysfunction. Although Wernicke encephalopathy may be seen in conditions other than alcohol use disorder, anorexia, hyperemesis gravidarum, the risk of Wernicke encephalopathy progresses to Korsakoff syndrome is much higher in alcohol use disorder than in other Wernicke encephalopathy associated conditions. However, in some patients who abuse alcohol, KS may develop without recognized acute episodes of Wernicke seen in this patient. Okay. Is it paranoid personality disorder? Is it antisocial personality disorder? How will it differentiate this? Antisocial is like violating social norms and this and that. We know that, and it is after age 18. Okay. So this patient's reckless disregard for safety and self and others, unstable employment, unstable employment history, and lack of remorse are suggestive of antisocial personality disorder. Antisocial personality disorder is a lifelong disorder characterized by pervasive pattern of disregard for and violation of the rights of others, beginning in childhood and early adolescence and continuing into adulthood age more than 18 required for diagnosis. An essential features for diagnosis of antisocial personality disorder is evidence of conduct disorder prior to age 15. This patient's history of truancy and fighting from middle school onward. Individuals with antisocial personality disorder tend to be physically aggressive and impulsive and may repeatedly get into fights. Additional typical behaviors include illegal activities, illegal activities, illicit drugs use, theft, lying, and manipulation of other personal gain. These patients' arrogant self-appraisal, lack of remorse, and failure to accept responsibility for his own behavior, blaming teacher for not getting into college, are characteristics of antisocial personality disorder. Okay, why it is not paranoid? Which one? F. Individuals with narcissistic personality disorder often exaggerated sense of self-importance and lack of empathy, are individual impulsive, and do not typically engage in violent or illegal activities. In paranoid personality disorder, behavior is motivated by distrust and suspiciousness rather than a desire for personal gain or to exploit others. Next. Catatonia. Neuroleptic syndrome, yes. Okay, it's benzodiazepine. This patient's history of severe bipolar disorder and current immobility and mutism are suggestive of catatonia. Catatonia is a syndrome, not a specific disorder. Specific catatonia is a syndrome, mm, not a specific disorder of marked psychomotor disturbance that occurs in severely ill patients with mood disorder and psychotic disorder, autism spectrum disorder, and medical conditions, infectious, metabolic, neurologic, rheumatologic. Common features include decreased motor activity, lack of responsiveness during interview, posturing, weak flexibility, initial resistance to repositioning the examiner, followed by maintenance of new repositioned posture. Catatonia can range from stupor to marked agitation. Catatonia excitement, which contributes to difficulty in recognition. Treatment of catatonia includes benzodiazepine and electroconvulsive therapy. A lorazepam challenge test individuals lorazepam 1 to 2 milligram resulting in partial temporary relief within the 5 to 10 minutes confirm the diagnosis. A catatonia generally responds to lorazepam within a week. ECT is the treatment of choice patients who do not improve. Next. Is he has a major depressive disorder, excessive anxiety, generalized anxiety, is recently diagnosed. Okay, recently diagnosed. Okay, okay, fatigue, weight loss, diabetes, pancreatic cancer. So this patient This patient has some features of major depression, anxiety. However, given his age, smoking history, marked weight loss, recent diagnosis of the diabetes, this patient is concerning for pancreatic cancer. Depression and associated anxiety may be prodromal feature in more than one-third of the patients with pancreatic cancer. Patients may describe non-specific anxiety, a premonitory sensation, and feeling low for no reason. The mechanism is not clear, but the hypotheses include an increase in inflammatory cytokine interleukin 6, a paraneoplastic syndrome, and alteration in pancreatic function hormone secretion. As seen in this patient, new onset typical diabetes may also precede diagnosis in up to 25% cases of pancreatic cancer. In these patients, the pathophysiology of the DM is possibly due to cancer-induced beta cell dysfunction or secretion of adrenomedulin and insulin regulating peptide hormone. Therefore, the next step in the workup of these patients suspect pancreatic cancer should be CT scan of the abdomen, which is preferred initial imaging test in not jaundiced patient. In non-jaundiced patients are presenting with severe weight loss and other suspicious symptoms. Okay, this patient is acutely psychotic and require prompt treatment with antipsychotic medication. Although he responded to haloperidol during the previous episodes, he experienced major tolerability issues due to extrapyramidal symptoms, CPS, acute dystonic reaction, akathisia, which is contributed to his subsequent non-adherence. EPS are more common with a high frequency first generation antipsychotics such as haloperidol due to their potent dopamine D2 antagonism in the nigrostriatal pathway. The best approach in this patient would be to treat with a second generation antipsychotic ziprasidone, as it reduces the risk of extra EPS. Among the second generation antipsychotic, ziprasidone has a low metabolic risk profile, olanzapine is associated with highest risk of weight gain and metabolic side effect, insulin resistance, hyperlipidemia, and should be avoided in this patient due to history of type 2 diabetes mellitus. Other second generation antipsychotics with lower metabolic risk include aripiprazole and lurasidone. Risperidone and olanzapine for obesity. Okay, it's delusional disorder. So, this patient history of persistent delusion about being poisoned in the absence of prominent psychotic symptom, in the absence of other prominent psychotic symptom, is consistent with delusional disorder. Her behavior unrelated to delusion, her behavior unrelated to delusion does not appear to be bizarre or odd, or she is able to function at work. Delusional disorder may be subtyped based on delusional theme: persecutory, being poisoned, harassed, plotted against; erotomonic, false belief that someone of higher status in love with him; grandiose, great talent, insight, achievements; jealous, and somatic, bodily function sensation. Delusional disorder must be differentiated from other psychotic disorder. Patients with schizophrenia have additional psychotic symptoms: hallucination, disorganization, negative symptoms, and a greater functional deterioration. Okay. Yes. Okay, pharmacotherapy for smoking cessation, long acting along with the short acting to improve efficacy. It is a memorizing question. Okay. What does he have? Okay, this patient's month-long history of feeling stressed and overwhelmed, experiencing sleep disturbance with possible nightmares, engaging in avoiding behavior following an acute MI, and his cardiac arrest suggestive of PTSD. Okay, yes, he has bipolar, isn't it? Um, is it MDD? Hypersomnia vivid? Is it cocaine? So these patients, oh, what's happening to me? Okay, these patients acute onset of depression with pronounced fatigue following a period of increased energy is suggestive of cocaine withdrawal. Individuals often use cocaine in binge and taking the drug repeatedly over a short period to maintain their high. Abrupt cessation is typically being followed by a crash, which can include severe depression with suicidal ideation and psychomotor slowing, and milder symptoms that resolve within 1 to 2 weeks. Cocaine withdrawal involves predominantly psychological feature. Common symptoms include depression, fatigue, hypersomnia, increased dreaming, hyperphagia, impaired concentration, and intense drug craving. Physical symptoms are minor and rarely require treatment. Got it? Yes. These patients' normal physical examination and vital signs make alcohol and opioid withdrawal symptom unlikely. Alcohol withdrawal is characterized by CNS hyperactivity. Its symptoms include anxiety, insomnia, tremulousness, tachycardia, hypertension. Opioid withdrawal typically presents with dysphoria and is accompanied by myalgia, yawning, and abdominal cramping. Physical findings include mydriasis, lacrimation, increased bowel sound, and piloerection. Okay, okay, bye bye. Tomorrow we'll start endocrine.